everyone, welcome to tonight's speaker series. Welcome to October, of course, Breast Cancer Awareness Month. We are always in Breast Cancer Awareness Month, quite frankly. Every day is Breast Cancer Awareness Month for Unite for Her, but we know that there is quite a spotlight on this month, and we want to bring you incredible topics that are going to help you understand and how to navigate your own questions and things that might be front and center that you just need more information on. And that's what the speaker series is all about, really being thoughtful and bringing you different topics that are going to help you move, to the next level and help you feel more empowered. And today is one of those topics, right, Erin?
Yes.
So yeah, we have to thank our presenting sponsor, that is West Pharma. We can't do any of this without our presenting sponsors and our supporting sponsors. So Erin's going to pop on that slide. You'll see her education, her speaker series education sponsors, with West leading the way, and our supporting sponsors being Daiichi Sankyo, Merck, and Seagen. Again, we can't thank them enough. They sponsor us all year long so that we can bring you the best and execute this whole entire series. Keep it logged on our library and make sure that you have access to it as well. Erin, do you want to give them a little bit of a what's coming up? Because we have a couple things coming up for our next one, just so people know.
Oh, absolutely. And this is one of those topics that I know we hear so much about when we are connecting with our community. So for those that have attended some of our virtual educational events in the past, you may be familiar with our partners at Revital Cancer Rehab. We are bringing them back, and one of their physical therapists is actually going to speak to us about peripheral neuropathy. So I was actually just having a conversation and telling one of our participants this afternoon that we are having this series, and it's something we hear: hands, feet, the difficulty with standing, moving, holding, the pain, how it affects sleep. So we know that, day to day can be really affected and changed as a result of this. So they're going to be educating us a little bit on why this happens and what we can do about it, because there are some really wonderful exercises and techniques and therapies that you can do with a therapist, but also at home. So I think that this will be, all just like tonight, another great learning opportunity for all of us. And that will be Thursday, October 20th, same time, running 6 p.m. to 7 p.m. Eastern time.
Awesome. Thank you, Erin. We actually have 2 speaker series this month. Usually we do one, but it is, they're just, the topics are coming fast and furious, and we really want to be able to meet our community with all the, interests that they have. So that's another one. So thank you, Erin. A little bit of the housekeeping, just remember to mute yourself, right? So we can have our speaker front and center, Dr. De La Cruz. Please use the chat. Erin and I are going to be watching it all night. So we'll be watching. It's going to be interactive. We love seeing these questions here, and we will then present them to Dr. De La Cruz throughout the presentation. Or if we feel like we can hold it, we'll do it at the end. If you want to raise your hand and in the chat, you see that little button down there. They are the reactions. You can do that too, and we'll be able to get your attention and see what you need. But without further ado, I am going to introduce you to our guest speaker tonight. So Erin, if you want to put her front and center, Lucy Maria De La Cruz, Dr. De La Cruz, has joined MedStar Georgetown University Hospital as the Chief of Breast Surgery Program and Director. The name of the breast center is Aurisman, correct? I always feel like I say that wrong.
It's the Betty Lou Aurisman Breast Center, yes.
Thank you. Thank you. She is also the director of the hospital's breast surgery fellowship program. Dr. De La Cruz is a fellowship-trained breast surgeon who specializes in a number of advanced procedures, including wireless lumpectomies, hidden scar technique, and nipple-sparing mastectomies. She has been published in more than 24 scientific papers, and her pivotal paper on nipple-sparing mastectomy oncological outcomes has been cited worldwide. She is currently a peer reviewer for the Annals of Surgical Oncology and is fluent in English, Spanish, and Portuguese. So, Dr. De La Cruz, you are very special to our community, sit on our advisory committee, helped us expand nationwide. Thank you for coming. I love when we have our conversations, they inspire me. And this was a topic that I remember sitting down and saying, okay, please come in and let's talk about this in October. And that was a long time ago that we did that.
Yeah.
Yeah.
Actually, yes. And I remember, Sue, that, our discussion started on pretty much our, my experience as when I was in training, and kind of where it started for me as a medical student and what I saw, and thankfully what we do today for our cancer patients and the evolution of surgery. And you said, Lucy, I think this is what you should talk about in our series. And I think this would be great for our population and our patients and to hear. And so this is where the inception of this idea came about. And here we are today. Probably 5 months ago, we had this idea, and but I think it's a great month to talk about this. It's it's not only Breast Cancer Awareness Month, but it's also Hispanic Heritage Month, which is I'm Latina, and I'm proud of it. And as a minority woman, it's definitely something that that I'm very proud of, to be a part of a community, but also to have seen the evolution of breast cancer surgery, and to do it and get to do it every day, and day in and day out for my patients.
Awesome. Thank you. All right, we have your presentation front and center, so I will let you take the floor, Dr. De La Cruz.
Perfect. Thank you, Erin. So do I tell you to pass the slide? Is that how it goes, Erin?
Yep, when you're ready to advance, just
Perfect.
let me know. Yeah.
Thank you. So obviously, Sue has already introduced me. My name is Lucy Maria de la Cruz, and I'm the Chief of Breast Surgery and the Director of the Orisman Breast Health Center at the MedStar Georgetown University Hospital. And I'm going to be talking to you all about the advances in breast surgery. Erin, you can move forward. So this slide is pretty busy, and I'm not really going to go into each detail of this, but it's mostly to kind of bring light to the evolution of research that has led us to essentially to talk about the downstaging or the de-escalation of surgery in the breast for women with breast cancer. And as you can see, the first big study that was done in 1971, so it wasn't too long ago. Most people feel that studies have been going on for hundreds of years in breast cancer, and really it wasn't. I mean, 1971 was not too long ago. Was a paradigm shift, and this is the one that really turned and said, wait a second, we don't have to do these radical surgeries because patients really don't improve outcome from removing all this chest wall. So this was in 1971. And after that, in 1976, when people were starting to say, wait, we don't have to remove the whole breast to be able to treat women. We could actually do breast conservation. And that's when the concept of breast conservation surgery or lumpectomy became a thing. And not too long, or not kind of around the same study, or not around the same time, there was the Milan study in 1973, which also looked at breast conservation plus radiation versus mastectomy. So I always bring this up because, we've done so much in such little time for breast cancer, and in part has to do with the push and the kind of the devotion of the clinical, the clinical field and the clinical specialists devoted to research in breast cancer. And I talk to patients about this all the time in my clinic, because a lot of patients are skeptic in becoming involved in clinical trials. And, if without the patient involvement as well as the clinician involvement in clinical trials, we wouldn't be where we are today as far as making advances, not only in surgical aspect, but also in medical management of the disease. And so all of you today, I want to bring this up so that hopefully you will never be in this, go through cancer again. But if you know anybody out there who's going through it, let them know how important their participation in clinical trials are. Because of people behind us who've participated in clinical trials, we are able to make change that has caused paradigm shift in treatment that have led us to what I'm going to talk to you guys today about. And so that's why I bring up this slide, to tell you that women behind have actually paved the road for women in front. And this is why this slide for me is so beautiful, because this tells us the story of thousands of women who have actually showed the way and have given their story and their journey to science, so that we today can do what we do for all of our patients. And so you can kind of move the next slide. So as I mentioned to you, in 1973 and between 1971 and 1973, the concept of breast conservation started. And I always go back to this time in medicine. So you have to understand that in the 70s, most women were diagnosed with palpable masses. And the reason why palpable masses were most commonly the way that patients were identified was because most women didn't get mammograms. And so they went to the doctor, they had a lump, and they didn't have, they didn't have a mammogram. They just had a lump and they went to the doctor and they removed it. And then they didn't even get a biopsy beforehand. Most of you who are on, who've had breast cancer, who are on this call today or on this Zoom meeting, you will know that you had a core biopsy. They had a pathology from this little piece of tissue that was looked at before you had surgery. In 1970, most women had surgery up front without a core biopsy. And the advent use of mammogram has allowed us to identify more early stage breast cancer, which has improved survival. So because in 1960 and 1970, mammograms started, we started picking up earlier stage breast cancer that was no longer palpable. So how do we find that in the operating room? How do we identify this if we can't palpate it, we can't feel it, we can't see it? And so then the surgeons and the radiologists came up with this idea. Let's put a wire in. Let's put a wire under mammogram, and we'll put a wire so that the surgeon can track the wire and find it. And we used wires, I don't know, up to 2005. Up to 2005, the wires were a thing. So for about, I don't know, 20, 30, 35 years, the wire was used. And you can go back still to that. So as you can see, the wire, patients used to be in the pre-op area with a wire sticking up out of their breast, waited for hours to have surgery. And to be honest, I trained in 2010 and they were still using wires. I thought it was the most archaic thing in the world. I thought to myself, it was probably a guy who invented it. No offense to men out there. But it's truly, I thought we could do better. We could do better as a society. We could do better as physicians. And thankfully, around that time in 2005, there had been companies that had looked at doing procedures in a way that was wireless. And they were talking about radioactive seeds. They were talking about other techniques. Now, during this time, we were still doing incisions, as you can see there by that arrow, that were not hidden. They were anywhere in the breast because the wires wouldn't allow us to do hidden scars. We had to accommodate to where the wire was coming in, where the wire was coming out. And we were limited by the positioning of the wire, the way that the radiologist placed it. We were really limited as surgeons to do our job to have better cosmetic outcome. And really wasn't even in the discussion to have good cosmetic, meaning it wasn't even an issue. Oh, it doesn't matter how you look. That was the way that I was taught, when I was a medical student in 2000 to 2004. And then when I was a resident, nobody talked about how you looked. It didn't matter. It doesn't matter how she has cancer. It doesn't matter. Just taking out the cancer, that's what matters. That's how I was taught. And I thought to myself, wait a second, what do you mean it doesn't matter? There's life after cancer. There's intimacy after cancer. There's womanhood after cancer. There are breasts after cancer. We have to do a better job. And thankfully, our society and breast surgeons and radiologists thought the same. And now, if you can go ahead. And so the introduction of a lot of technologies brought wireless lumpectomies. And this was a game changer for a lot of us surgeons. The wireless lumpectomies, which some of you had, some of you didn't have, was the idea that you placed a clip where your biopsy clip was. And some of these technologies we use a guide in the operating room that guides us to find that area of your cancer in the operating room. Now we, the surgeon, can determine where we make the scar. Now we can be thoughtful of doing the scar in a place that will be more pleasant in the breast, that could be hidden, that could be more likely to heal nicer, that could leave less of a defect. And this, I will tell you, in a lot of places today is a reality. Unfortunately, in some places, it's still not a reality. And that is something that we are still struggling as a society to change the practice of a lot of surgeons who have been trained with wires to adapt to lumpectomies that are wireless lumpectomies, because we do know that it impacts surgical planning as far as where the scar goes, where the area of cosmetic, meaning that it looks nicer when you remove the cancer, where you can do your incision around the area of the nipple. And in 6 months, it'll heal in such a way that you won't have a scar that it's visible, or that you can wear a low cutting shirt, or you can wear your bathing suit in the pool or in the beach and nobody will know you had breast cancer surgery. And so these are things that now we discuss as a society. I discuss with my patients day in and day out. I say, we're going to do a hidden scar. In 99.9% of my patients who do lumpectomy, I don't do a scar anywhere else but around the nipple areolar complex, meaning the brown or the pink area around your nipple. Mostly because that area heals very nicely, because it doesn't leave a big defect, and because it could be hidden and you could wear whatever clothes you want, whatever bathing suit you want, and nobody will notice that you had surgery. So these are things that actually excite me. When I started residency or when I started medical school, we used to do huge scars. We used to live huge defects. And now I do surgery through tiny little scars. I remove cancer, and by patients at 6 months, they come back and they're like, doctor, I had a mammogram today and my mammogram tech couldn't even find the scar to put the little sticker on before I did the mammogram. That brings me joy. That is what I strive for in every single one of my patients. And so I think that all of us should strive for that. And ultimately, I hope that all of you have that. And all of the people that you know who are going through a breast cancer journey seek that as well in their breast cancer journey. So also, the other thing is breast conservation used to be only for patients who had small tumors. And I remember I was taught the idea that if your tumor was larger than 4 centimeters, that you couldn't have a lumpectomy. That was it. You had a mastectomy. And so patients were deemed not breast conservation patients. You could, if you have a tumor that's 4.1 centimeter, you have to have a mastectomy. Well, thankfully, that's not the case anymore. The Veronesi group out of Italy had been doing something called oncoplastic surgery. And this was done since the 1990s. They had published tons of literature on it. And unfortunately, the United States, we were late adapters to it. And if you can pass the page. And I'm sorry, I'm going to go back to, this is the hidden scar that I was talking about. No, you can go back to the hidden scar. So this is what I was talking about, the hidden scar. So this is around the nipple, and the inframammary fold, which is the green scar, which is also hidden in cases of patients who have really low tumors, that you may be able to use them, so that they're hidden in the inferior border of your breast where your bra goes. And these heal extremely well. They look beautiful. They don't cause divots. They heal so nicely that patients are very, very happy at 6 months and even a year afterwards. And this is called a hidden scar lumpectomy. If you can go ahead. Now, this is what I was talking about, oncoplastic breast surgery. So, we talk about it, and this is called making cancer surgery look better. So if you look at the top picture on the making cancer surgery look better, you see the old way of surgery training used to say that it didn't matter where you made the scar, that the problem was just to remove the cancer. If you had a cancer that was in the upper inner quadrant of the breast, so here in like the cleavage area, just do a scar there. It doesn't matter. If you had it doesn't matter where it is. Just on top of the tumor, you make a scar, you take out the cancer, and you close. We do not do that anymore. We now are thoughtful of preserving the breast to look like a breast. We're thoughtful of where we plan the scar, and this is either with a hidden scar or something called oncoplastic breast conserving surgery. So in this picture, you'll see a lady who had a large tumor, who was a patient who obviously did not want to have a mastectomy. And in old days, they would have told her, you cannot have a lumpectomy because your cancer is 4 centimeters. In 2022, she will have a lumpectomy and something called oncoplastic, which is usually a lift and a reduction at the same time. Now, this can usually be by several techniques, which is usually determined by either the breast surgeon or the plastic surgeon. In my practice, I do it together with a plastic surgeon, and we plan it and we do it all at the same time. We do it in a way that I take out the cancer and the plastic surgeon does the lift and the reconstruction. And they do it for both sides. Insurance covers it, and it's covered by a Symmetry Act that was passed. So all patients who have cancer, our insurance should cover symmetry surgery or reconstruction surgery. So all patients now, when I see them in my office, I look at their breast size and their tumor size. And according to tumor breast ratio, we determine if they're candidates for this, if they want to have preservation of their breast. Now, if you have A cup, right, if your size is very small and you have a 6-centimeter tumor, you can't have breast conservation even with oncoplastic surgery. But if you have a D cup and you have a 4-centimeter tumor or a 5-centimeter tumor, you can have a lift, a reduction, and a lumpectomy at once, because your breasts are big enough for you to for me to take out 5 centimeters of cancer and for you to have a lift and a reduction. And they will do the same on the other side so that they both match. And this has been deemed oncologically safe by multiple studies. I actually did a large clinical study on this that was published, and it's cited worldwide, and it's equally safe, oncologically safe, as equal outcomes to lumpectomy alone. And today is considered standard of care on patients who want to have breast conservation and want to preserve their breasts, who have large breasts and who have larger than normal tumors. If you can move forward.
Dr. De La Cruz, can I ask you a question real quick? Our chat, the ladies are talking in the chat and actually just putting some of their experiences in. When you talk about oncoplasty, is that only for this particular type of lumpectomy that lifts up the skin, pulls from underneath, comes back under, and it's around the nipple? Is that what that term oncoplasty means? Because I don't know if everyone is following. Is it a broader term and there's other subsets within it, or is that just that one procedure?
So oncoplasty means that we remove the cancer and the plastic surgeon does a reconstruction of the breast, but of your actual native breast without it being a mastectomy. Okay. So they can do that whatever shape or form. And that's why I put that drawing underneath the picture of the lady, because there are many ways of doing it. There's not just one way of doing the oncoplastic approach. It depends on where the location of your tumor is. It depends on where the shape of your breasts are. It depends of the size of your breast. But oncoplastic means that it's oncologic surgery with plastic surgery together, preserving the breast.
So no more lumpectomy. It used to be called lumpectomy, but now it's called this oncoplasty surgery because it's more capable of really hiding the scars and actually going in and getting larger tumors, it sounds like, because I know I didn't have an option at all. It was mastectomy.
Yes.
Yes. I would see, they estimated between 3 and 5 centimeters. So it was just mastectomy. That's just what it was.
That's what it was in 2004. Mm-hmm. So today, if you have a 4 or 5 centimeter tumor and your breast size is CD cup, then we would do a lumpectomy with oncoplasty, meaning I take out the cancer, I do a lumpectomy, and then the plastic surgeon, with whatever breast tissue is left, he puts it all back together and shapes your breasts back together.
Gotcha. Okay.
And that is what oncoplasty means. Oncoplastic means that they fix up whatever's left of your breast. Normally, so let's say you don't have cancer and you have large breasts and you want a reduction. The plastic surgeon will take out a piece of, a section of your breast to reduce the breast in size because you want to have it smaller. What I remove is that equivalent, right? I take out the area of the cancer, and then the plastic surgeon says, okay, she took out 5 centimeters of tissue. Okay, whatever's left, I put it back together. So now instead of having a D cup, now you have a C cup. And then they go on the other side and they take out the same amount of tissue that I took out on the cancer side on the other side to match it. So both breasts are equivalent, are equal.
Great, thank you.
So there's a question here that I want to address. There are some breast surgeons that do oncoplasty. I do some oncoplasty that is not complex. There are some large oncoplasties, like for example, there are patients that are really large that I don't personally do, and they're better off with a plastic surgeon. But yes, for example, there are patients that have, let's say I have a patient who has large breasts and I take out a 4 centimeter tumor, but they don't want to lift. Then I do some tissue rearrangement so that they don't have a divot, so that the tissue doesn't go in. And when they get radiation, it doesn't sink in the area where her previous cancer was. And that is also oncoplasty. Those are different techniques that we have in our teaching that we use in the operating room to allow for better outcomes after surgery on patients that we operate on without needing to have plastic surgery in the operating room. I hope that answers the question. I mean, we'll have time when I'm done to go back if you want, or do you want to do it now, Sue?
No, I think you did. She actually is responding back in the chat too, because that physician, let me see if this is the same one responding. Yep, that they mentioned, tissue rearrangement. So you are talking about all of these terms that are connected. I remember the divot too. I have those too. I have those because that's just where I was. It actually was 2009. I waited until 2009. So it's very interesting to see how far it's come, and really, really exciting for those of us that are, faced with getting this surgery.
Yeah. So breast conserving with oncoplasty does not change the fact that patients may need radiation afterwards. Okay. So radiation has nothing to do with surgery. Radiation is a local therapy. Radiation is and surgery is a local therapy. Oncoplastics is a surgical approach. It doesn't replace radiation. Just FYI, just wanted to let everybody else know as well. Radiation is added on to this as well. Okay.
Yep.
So I'm gonna move on with mastectomy. So obviously here it's a very I like showing this because this shows us somebody on the Halsted, which is the radical mastectomy. You can see she has a wound there. She's got contracture of the shoulder, which is what we used to do before 1971, to a modified radical mastectomy, which was done in 1970s. I'm sorry, so Halsted was done in the 50s. Modified radical mastectomy was done in the 60s and 70s. After the 70s, when the first trials came out, then we did skin sparing mastectomy, which is the far right of the image study and the imaging, which showed that, these patients, all of these patients had the same survival, interestingly enough. So no matter how you looked, all of these patients live the same. How impactful is that? So we did all of this and these patients still lived the same. To me, when I saw this time, when I remember when I first saw this, it broke my heart because, we didn't know, right? And we don't know what we don't know. And I'm thankful, like I said, and that's why I showed that first slide, because of those women who participated in those clinical trials, we are where we are today. And so I am sincerely a believer in clinical trials, and I can't say this enough, because every time I see my patients, I say, thank God for those women behind us, because if not, we would still be doing that Halsted mastectomy. We would still be having women in my office looking like that. And I don't know if I could live like that, knowing that I'm doing those kind of surgeries. They're awful surgeries to do because they are debilitating. The quality of life are really hard for patients. They can't move their arm. And so thankfully, patients, even in the far right, I saw them and I said, we can do better. And I remember when I was a resident, I asked my attending, I said, what is the survival benefit of, skin sparing versus nipple sparing? She's like, there are only small studies that looked at this. And I said, well, why hasn't anybody done this? Why hasn't anybody looked at this data? Well, it's a lot of work, and well, why hasn't anybody looked at like the outcomes between, modified radical mastectomy and skin sparing and nipple sparing? Well, that takes a lot of time. This is what my teacher used to tell me. I said, well, somebody has to do this. And that was my project of love. And I did that when I was pregnant as a third-year resident. It took me 9 months, and I published this paper at the American Society of Breast Surgery that published and said that nipple-sparing mastectomy was oncologically safe for women with breast cancer, and that their outcomes was equivalent to skin-sparing and modified radical mastectomy. And if you can move forward. And I remember I presented at the American Society of Breast Surgery in 2015. And I asked in a room filled with 2,000 breast surgeons and general surgeons. And I asked, how many of you do nipple-sparing mastectomies? And only 5% of people raised their hand. 5%. That also broke my heart. That was only 7 years ago. That was not too long ago. And so after that paper was published, I can tell you that probably a lot more people are doing nipple-sparing mastectomy. Unfortunately, not everybody's doing nipple-sparing mastectomies. Not everybody's a candidate for nipple-sparing mastectomies, right? So, and the reason why I bring this up is because today we are pushing the envelope on who is a patient who requires a who is a candidate for nipple-sparing mastectomy. So patients who are genetic mutation carriers are a candidate for nipple-sparing mastectomy. Even if you have cancer, by the way. Patients who have, as long as your nipple is not involved, you are a candidate for nipple-sparing mastectomy. If your nipples are in the correct location, meaning they're not, below your inframammary fold, kind of where your bra goes, you are a candidate for nipple-sparing mastectomy. And those are discussions that you can have with a plastic surgeon and your breast surgeon. As far as if you're a candidate for nipple-sparing mastectomy, if your breasts are adequate for a nipple-sparing mastectomy. Now, this used to be a teaching up to probably the last 2-3 years. You had to have a small breast size, so less than, A, B, C cup. And your nipples had to be above your inframammary fold. So the crease below your breast. Okay. And that's how I used to practice. That's what most people used to practice. And I think we are now evolving, and I don't think most centers do it. I would tell you, you have to go to someone who's done a lot of these. And I'm going to talk about something called a wise pattern or a vertical pattern nipple-sparing mastectomies. I do them in my clinical practice. Not a lot of people do them. They're doing them in Europe. There's a lady called Anna Pellet who does them in San Francisco. Very few surgeons do them. And actually, so you're going to see these. There are 2 women in this picture. There's the one on the left-hand side who had her nipples are in the correct location, and she had a regular straight-up nipple-sparing mastectomy where her incision is inferior border. And you can see on the left of that picture is her regular breast, and on the right is her nipple-sparing mastectomy. This is a great surgery. She looks phenomenal. That's what most of my patients look like when they have nipple-sparing mastectomy. They look like they had breast augmentation, pretty much. There's a preservation of the contour of the cleavage. We don't have loss of the cleavage. So when, we used to be taught that your breasts go up to here to the clavicle. That's not necessarily true for everybody. Your breasts don't go up to the clavicle. Your breasts, you do have fat there. You have, you don't need to remove the fat that goes up to the clavicle. There's a transition zone. So that woman there on the left-hand side of our screen had an amazing nipple-sparing mastectomy, and she looks phenomenal. Now on the right-hand side, this woman, you see, she has asymmetry. And I say that most breasts are sisters, not twins. So on her right, if you turn her around, her left breast is a little smaller on her right side. And her nipples are not in the correct location, right? So if she comes to my office, I will tell her, your nipples are not in the correct location, but we can do something called a lift, which is a wise pattern lift or a vertical pattern lift, and a nipple-sparing mastectomy all at once. And we will lift her nipples. So you see on the picture next to it, her nipples are lifted and she's reconstructed. And that is the future of nipple-sparing mastectomy, where you can have one surgery, all one stop, and she's had what she's probably always wanted, to have symmetric breasts, her nipples in the correct location, but now she's had a bilateral mastectomy and she's had symmetry and she looks great. she actually probably feels that she has much more symmetry than she did before. And it's kind of like a silver lining, right? This is what you, as us, as a surgeon, at least me as a surgeon, hope to provide our patients. So this is what excites me about the evolution of our surgical practice in breast cancer treatment, where patients come in telling me, you know what, Dr. De La Cruz, this patient was asymmetric. My nipples are not in the correct location. I've always wanted to have breast augmentation. I've always wanted to have a lift. I've always wanted to have symmetry. I now have cancer, and my insurance never covered the other stuff that I've always wanted to have. Can I have everything done, one surgery? And I can. I've been able to do that for her. If you can transition. And now the other thing is the future. And this is something that I've actually started doing, which is, so a New York Times published a paper, an article, probably 4 years ago or 5 years ago, talking about a patient who felt numb after nipple sparing mastectomy, and saying how her surgeon had never talked to her about loss of sensation. I've been talking about loss of sensation since I was a resident. My mentor talked about it with all her patients. And it was something that was told that, I thought it was very important to talk to patients. A lot of women are impacted sexually by loss of sensation of their nipples, or even loss of sensation of their chest wall during intercourse and during intimacy. And so I always bring it up in my preoperative visit with patients when I'm consenting them. And I thought to myself, how could I talk to patients, and how could I fix this, and how can I help them? And I mean, anatomy and physiology, there are nerves, right? Where are the nerves? In the chest wall. The safest and the easiest nerves to save are the superficial nerves, which innervate the lateral aspect and the superior aspect of the breast. And those I've been preserving for the last 7 years since I've been doing mastectomies. But the future is truly potentially re-implanting the nipple innervation, which is the T4, it's the thoracic 4 nerve, back into the nipple after a nipple sparing mastectomy. And actually, I've been we've just started doing this in the last 6 months at our institution. Anna Pellet is one of the pioneers out of San Francisco. And, this is the future. If we could potentially bring back at least some sensation to our patients. I know laterally and medially, our patients, at least my patients, have a lot of preservation of sensation. But if we can make them look and feel the closest to home as possible, then I feel that I have done my due diligence. And I tell my patients, I can die tomorrow and die in peace. I know I have fulfilled my purpose here on earth. What I was sent here to do, I have done. And so with this tone, I am going to end this. And I hope that all of you guys have learned a little bit of something of all this exciting news. And I look forward to answering any of your questions.
It's perfect. Thank you, Dr. De La Cruz. And I thank you for pushing through too. I know you have been under the weather, and you just have, given an incredible presentation. I have learned so much. I can relate back to 2004, 2009, especially the sensation. Oh my goodness, if that can happen, that would just be, because it is, you miss it. I know that a lot of women talk about their sexuality, and like you, I am very upfront with them and just say, just so you know, like you will miss that. However, it's a trade-off. So that would just be incredible for my daughter and everybody else who's, in the future that we might feel have a higher chance of getting breast cancer, to know that this could be an option. Be incredible. Okay, there were a couple questions here. One of them being, what are the choices for people who already had mastectomies?
Choices for, what do you mean?
She's probably thinking nipple sparing, but there is no, there's not much there, if that's what you're thinking about. It's so raw.
So if you've had a skin sparing mastectomy, you could always have nipple reconstruction from a plastic surgery standpoint. It wouldn't be your nipple, but it would be, they do a neo nipple and the nipple tattoo. Unfortunately, there's no way of kind of going back for a nipple graft or anything of that sort.
Yeah. Yep. And then there was another one, we went back a little bit, and Erin, I don't know if you grabbed that. You answered about the BRCA gene, that they do qualify. So someone had asked about that. It's actually, your timing was spot on. The other one was just talking about, was the procedure done prior to radiation? And if you can just answer that question when someone has to have radiation.
So the oncoplastic breast conservation can be done, yes, before radiation. If you've had radiation in the past and you get breast cancer again, if you've had it within a year and you require, yes, you can have breast conservation with oncoplasty again.
Okay.
If that answers your question.
Yep, you can pop it in the chat if that answered your question there. One other one was about radiation as well. And since we do have you on and your wealth of knowledge, let me know if you can talk to this as well. So very helpful. She was very grateful for all the information. She said, do you have any resources for radiation options, such as whether to have a radiation boost or decided between full or partial breast radiation? I guess that's a hard question.
So that's two different things. So first of all, partial versus a whole breast depends on your age, depends on the amount of disease, depends on your lymph node status, and depends whether you had lumpectomy versus mastectomy. So that's kind of a lot for, you know, a little bit of short time and with a little bit of information. So I'm going to kind of give you an overall view, but I can't really give you a straight up answer. So if you had a mastectomy, you're going to get whole breast radiation. If your tumor is larger than 4 centimeters, or if your lymph nodes are positive, or if you had inflammatory breast cancer. If you had a lumpectomy and you are over the age of 50 and your tumor is small, meaning less than 4 centimeters, and your lymph nodes are negative, then you are going to be a candidate for partial breast radiation. Everybody else will probably get whole breast radiation. The boost is depending on the radiation oncologist. Usually they'll boost somebody with close margins if you have a larger tumor or if your tumor biology is aggressive. That's like the 101. But again, I'm not a radiation oncologist. I'm just trying to summarize it for you.
Yeah, that makes sense. We also have a question from Erica just saying, you know, when consulting your surgeon prior to surgery, what questions can you ask regarding their familiarity with this procedure?
Which procedure? So nipple sparing, how many have they done? What is the nipple necrosis rate? If they do nerve preservation, and that's it. If they're talking about breast conservation with oncoplasty, if they do it themselves, if they use a plastic surgeon, and what happens if their margins are positive.
Okay. Want to do that one more time, Dr. De La Cruz? I just want to make sure she could have time to write them down.
Yes. So if they had a nipple sparing, if they're going to get a nipple sparing mastectomy, what is their nipple necrosis rate? If they do nerve preservation, and how many they've done?
Great.
And if they do breast conservation with oncoplasty, if they do it with a plastic surgeon, what do they do if they have positive margins?
Okay, terrific. Couple more. It's the chat is
That's
busy.
fine. They're
Okay.
great questions.
Yeah. Okay. So if you've already had a lumpectomy and have now had radiation, is it necessary to wait? Sorry, the question just popped up on me. To wait to do any augmentation. I was told to wait a year to give my skin time to recover because I would be disappointed with the results if I did it too soon.
Yes, absolutely. 1 year. You don't want to do anything before 1 year after radiation.
Okay. I had nipple sparing surgery done. This is Analia. Any hope of getting sensation back with new procedures, nerve transplant?
Yes. So there are some plastic surgeons who do nerve regeneration surgery with grafts. One of them is the Pellet Group out of San Francisco, that you may go online and find out. I don't know of any other group that's out there that's doing it after surgery. We do it at Georgetown, but we do it intraoperatively during the time of the nipple sparing mastectomy.
Okay.
But Z-Pellet does it after surgery, like, you know, for patients who've not had it during their nipple sparing mastectomy.
Okay. Erin, did I miss any? I see you following along with
Yeah, these
so
are
many-
great questions. There is a question just from our metastatic community just asking, can an MBC patient have breast reconstruction?
I mean, it depends. So technically, if your metastatic disease has been stable and you are, pretty much stable, and you are doing it just mostly for quality of life and for feeling good about yourself, you should talk to your surgeon about it, your plastic surgeon. As long as your metastatic disease has been stable for at least 6 months to a year.
Okay, that's a good recommendation.
Because this is the thing, you don't want to impact your systemic treatment. And so if you have reconstruction and you are currently on systemic therapy, that may impact your reconstruction, or your reconstruction, if it gets infected or something, that may impact your ability to get systemic therapy that you need. So that's why it's so important for you to coordinate with your medical oncologist and your surgeon, your plastic surgeon.
Really good recommendation. I don't, and just in terms of recommendations you've mentioned the group in San Francisco several times. Are there any other groups that you may be able to recommend on the East Coast, anywhere else in and or around the Philadelphia area that may follow the same surgical techniques?
For the nerve preservation, so I'll tell you, it's Anna and I right now.
Okay.
We're trying to create a training, a boot camp for surgeons to incorporate it into their practice. Look, nipple sparing mastectomy is done now in most institutions. You just have to be wary of how many they've done, their nipples necrosis rate. So I would tell you, in Philadelphia, Alina Mateo at Pennsylvania Hospital does it. Dalia Sadaloff is also a rock star. Kay Yoon Flannery at Cooper does amazing work. Rosa Mustafa at Capital Health, she's amazing. In New York, I can tell you that David Anderson does great. He's at Mount Sinai. If you go to Boston, let me see who's up. I could tell you, I could send you a list of people that I can go. I just have to think them off of the top of my head.
Yeah.
If you go to Florida, Julian Baracol in West Palm Beach. If you go to, I can give you a name and you can put them on the website for people. But the nerve preservation is truly like on the cusp of beginning of time. Like, this is the inception of something beautiful.
Very exciting things to come, for sure. Thank you for that.
And I think what I'm hearing too, Dr. De La Cruz, it's not the way it used to be, years ago when you asked that question and only 5% of the population raised their hand on nipple sparing. So our audience should feel good that their present doctor, they should ask them and start there, and then get directed from there if they feel like, they're not getting the results that they want. But there might be a good chance, higher, much more higher than it used to be, that they are doing this. Is that what you're saying?
Yes, 100%. There are more and more surgeons who are doing nipple sparing mastectomy, 100%. And I said the 5% in 2015, there's probably now 30-40% of surgeons who are doing nipple sparing mastectomies.
Okay.
It's still not 100%.
Yeah.
And
Okay.
interestingly enough, in a lot of the larger centers where you would expect to get nipple sparing mastectomy offered, unfortunately, a lot of them are not offering them to everybody.
Okay. Our audience would love a list. I hate to say that, but even if you just
That's fine.
the Philadelphia area,
That's
because
fine.
a lot of our folks are in the Philadelphia area. And I think that could be,
I have
ones that
colleagues.
you mentioned, like they're all our partners. We know all of them. And
I know, and I know everybody. I know all of them.
Yeah, it's
And
really
you
great
know,
for you to hear. Like, I love that, it just makes me smile. I'm listening to the names you're rattling off. I'm like, yes, yes, so
and I
good.
will tell you, I will only recommend people that I know and that I trust. Otherwise, I won't say.
Yeah.
Because I would hate for you guys to send somebody to someone that I'm like, oh my God. No, I will tell you. Otherwise, I will say I don't know them and I can't, speak for them.
And that's important. If you don't know them, like, please know you have to do your homework as well, right? She can't,
100%.
you can't know everybody, Dr. De La Cruz, right? So just please do your homework as well. And yeah, yeah. And she gave you all the good questions to ask. We'll grab your PowerPoint for sure and put that up, because we do keep this on her library. And Dr. De La Cruz, it was great. It was such a good way for us to have our first speaker series in October.
Well, it's been my pleasure. God bless everybody on this call. And I can't tell you how honored I am, and I feel so blessed. Thank you so much.
You are welcome. You are welcome. All right, Erin, do you
Well,
want to?
I missed.
Oh, go ahead.
I actually did not mention this, and I think, did a lot of people leave? Maybe we should do another day, another call,
They're still
another
on.
talk.
Mhm.
They're actually
So-
still on. Everybody's holding
so-
on with you.
Actually, I did not mention this, but I don't, and it's not because it's just as important. And I wanted to bring this up, and another patient population that it's true and dear to my heart are patients in the transgender population that I have treated. And I want to make sure that you guys are all aware that there are options for patients who come to my office. And there's many of us who treat patients who have breast cancer in the transgender population. And we do, top surgery for them at the time of the cancer procedure. And that used to not be the case in many times, and where they are either able to preserve their nipple with top surgery or not, depending on what their needs are and their and what their kind of what they want to do with their body. So ultimately, I tell patients when they come to my office, what is it that you want to look like? What is it that you want your body to feel like? And that's what we ultimately want to achieve. And I was telling Sue and Erin, I've done a lot of top surgery in our practice at Penn. When I went to Inova, I've done a couple in our current institution. We work with great plastic surgeons, and mostly it's to preserve the nipple. Sometimes you want to have the flat look, but with the nipple we do a free nipple graft after a mastectomy with the flat, no reconstruction. And that's something that nobody had ever talked about, and a lot of the patients in the transgender population didn't have the voice to talk about it. They didn't feel that they were being heard when they were going through cancer treatment. And this is something that I feel very strongly about. And I think all of us in the community should be vocal about it as well. And I know that Sue and Erin are advocates for the transgender population, and especially in our community. So definitely, we have, I speak for this as well as, in our community. We just had a meeting, BC3 for our breast community, our breast specialists or surgeons, radiation oncologists, plastic surgeons, and medical oncologists met, and we actually gave the first panel on transgender screening for mammograms and GYN screening for transgender population. And this is, really important. Nobody talks about it and we need to bring voice to this. Patients who are on hormone treatment and patients who are not getting screened, we need to talk about it. And patients who are going through cancer treatment, what surgical options we're talking to them about. And so, yes, we do offer that in our institution, and a lot of our breast cancer surgeons do offer that as well. So if you are a transgender patient, or if you know someone who's going through cancer, tell them to talk to their breast surgeon about top surgery in the setting of breast cancer.
Yeah, thank you so much. And you know what? I actually feel like we should do another speaker series, just that topic, Dr. De La Cruz. Could we just do that topic? That would be great.
You know what? We had this amazing talk about screening, and it would be a phenomenal talk. I think we should.
Let's do it. We might even have an opening early in November that just changed for us. So
November may be too soon for me. November is like killer for me. I have a lot of things happening.
We'll find a date, but I would love to do this. I know Erin and I would absolutely want to put this front and center. No one is talking about it. We're looking to be more, just understanding the sense of belonging and making sure we're getting the information out to our community that we love and serve. And
1,000%.
Yeah.
1,000%. And it's something that I want to get ready for as well. I didn't give the talk. I was there and I organized and I brought speakers, but it's something that I truly feel passionate about. So it's something that I would love to put together for you guys and be able to be
Awesome.
informative. So for your community. So
Oh,
please count me in. Thank
great.
you so much for everybody. And thank you for having me. It's always a pleasure. I love you all. You know that you guys do God's work, and thank you. I appreciate you.
Oh, thank you too. All right, Dr. De La
Thank you.
Cruz,
Take care.
later.
Bye.
Bye-bye. So good, Erin. Erin, you want to take us home?
Oh my gosh, I don't even know what to say.
No, I'm
Truly.
so glad we ended
She's
up, we talked
amazing.
about this earlier on. She hit on the topic of our transgender, and now we're able to, do a special speaker series just for that population. So I'm really
Great.
excited.
Yep. Everybody should have the same resources and feel wonderful in their bodies and happy with it. Look, and she just is truly an innovator, and so happy to have her with us. So, yeah.
Marika, we usually get these
Tomorrow
videos
morning.
really quick. Yeah.
Yeah.
No guarantee, but usually it's
Well,
very
I'll tell
quick.
you, I will record it tonight, and Rachel, I'm sure will have it up on her library. And I wanted to say, so I'm glad you asked, because I was going to call that out. And for those that want to write down those questions again, we're looking around minute 46, 47 if you're going to that video. So if you're looking to catch those questions that Dr. De La Cruz had us, minute 46, 47 in the recording, but I'm sure we'll have that up tomorrow morning, because I think we're all going to want to go back and sort of digest again the information we learned this evening.
Absolutely. Absolutely. And just know where you are right now. Ask those questions. The Philadelphia area, New Jersey area. Oh, we have incredible communities. So most likely you are going to find the answers you need right where you are. And if not, then you can try and, find what you're looking for and get some other advice.
Yeah, wonderful.
Okay.
This recording will go, Kat, this will be on her library. So if I can put the link to her library in the chat, but it's uniteforher.org/her library, where all of our education series are hosted. So all of our digital virtual events, you'll all find them there. So they will be there tomorrow morning for everyone. And hopefully you will join us for our follow-up speaker series later this month with our friends at Revital Cancer Rehab. Remember, we're talking peripheral neuropathy, doing some learning about that, working with one of their amazing physical therapists. So be sure to join us October 20th. Be on the lookout, social media and newsletter, for how you can register for that event as well. So we're so excited for that.
Terrific. Well, Erin, we have to thank our sponsors one more time. Right?
Couldn't do it without them. Absolutely.
Yeah. So
Presenting
thank you.
sponsor West. Yeah.
Yeah, thank you to our education sponsors that make this all possible. West Pharmaceutical is our presenting sponsor, and then Daiichi Sankyo, CGen, and I can even move to the side here.
I know. Love them. Yeah.
And our
They're
friends.
big supporters. Yeah. Of talks like this, they're why we can bring experts like Dr. De La Cruz to you. So thankful for them.